Dr. Shore, obviously with all the oncolytic therapies that are available and with the different mechanisms of action, the questions that we receive a lot is the concept of combinatorial therapy and sequencing. Obviously there are regulatory aspects, there are all types of issues that really we as urologists have to consider. But in a perfect world, give us kind of your thoughts, if you will, on how you view the various therapies in relation to its use, combination sequence in the castrate-resistant prostate cancer patient.
So the question regarding what's the best recipe for sequencing and or combinatorial strategies given our new advances is always asked, as it should be. It's a great question. And the challenge is we don't have the data to say with certainty what is the best recipe. We all want to know this. And fortunately, now we have a multitude of investigator-initiated trials that are ongoing, looking at sequencing of one therapy with another, combining another therapy with another. And we have to do that because we have to make sure that the sequence or the combination is additive or certainly not deleterious. We have to make sure that there are no new safety signals or adverse events that occur. You know, we intuitively feel that because the mechanisms of action are so different, we're not expecting to see challenges or dangers. And I think the field of urologists, medical oncologists, and radiation oncologists are very optimistic that we're going to see additive effect. It may not be completely additive, but I think we feel that it will be, the sum will be more than the parts separated. But at the end of the day, we're scientists and we have that, Missouri State adage, you got to show me. And that's how it should be. Otherwise we're just kind of flying by the seat of our pants, so to speak. In terms of current approved strategies, I'm a believer that you want to adopt the therapies that are most impactful early on, and we want to use the therapies that we think are best tolerated in combination with efficacious. So it seems to me that once a patient develops castrate-resistant prostate cancer, and they have radiographic evidence of disease, and if we're monitoring them carefully, screening them efficiently and propitiously, and not waiting for them to show up with high volume of tumor burden and on the cusp of becoming symptomatic, then if we catch them earlier with a lower burden of disease and with completely normal functional performance status, then I would see as a foundational therapy getting the Sipuleucel T in as early as possible. Because the immune system at that point should be as intact as possible, and immune therapy, the data suggests, takes a little longer period of time for it to take hold, to convert the immune system to break tolerance to the proteins that are associated with prostate cancer cells. Additionally, it gives one time to then monitor the patient and contemplate other therapies if they progress with new lesions or new symptoms. So I think from a foundational standpoint, I believe the Sipuleucel T should be certainly considered early on. Following that, right now, we don't have FDA approval in the pre-chemo space for any other agent other than second-line hormonal manipulations. I think we're all very excited and awaiting the FDA review of a trial known as the 302, the Cougar 302, which is a large phase 3 trial which looked at Abiraterone acetate for patients with asymptomatic, minimally symptomatic MCRPC prior to docetaxel. Right now, Abiraterone acetate is approved post-docetaxel. So we should actually be hearing by mid-December on the verdict of the FDA for abiraterone acetate pre-chemotherapy. The data was very nicely presented by Chuck Ryan at ASCO this year, and it clearly shows an impact on progression-free survival. There's an impact on overall survival at the interim, but we're still waiting for the final analysis to see if it meets the statistical significance. If indeed that gets approved, then we'll have another agent in addition to Sipuleucel-T to give to patients prior to considering chemotherapy. So that's the most up-to-date state of the art of where we stand. Many are interested in seeing the results of androgen receptor signaling blocker known as enzalutamide. It was just approved also post-chemo, much like abiraterone. It has also a pre-chemo trial that's pending, but the results of that won't be known for probably way into 2013 and perhaps even early 2014. Abiraterone and enzalutamide are both orally administered medications given once a day. Abiraterone requires prednisone 5 milligrams twice a day. Enzalutamide does not. There are some differences and therefore in the monitoring of these patients, but I think overall certainly something that urologists should be very comfortable in doing. Medical oncologists clearly are. And so if not by 2013 for enzalutamide, certainly for abiraterone acetate if we get a favorable review by the FDA. And therefore within the next 1 to 2 years we could see patients with early low volume metastatic castrate-resistant prostate cancer getting their Sipuleucel-T, possibly then being augmented with abiraterone and eventually or enzalutamide. Maybe it's one, maybe it's both. That's one of those combinatorial trials that we have to do to see if their impact is additive. And then we'll also have some results regarding, in the next couple of years, hopefully, maybe 2 to 3 years, the other immunotherapies which we'll have discussed for this program, and that would be ipilimumab and Prosvac. So these are being looked at, these two immunotherapeutic trials, also in the pre-chemo space. There's no perfect answer as to the exact timing and sequencing. But I think most of us feel that there's not going to be one single therapy that's going to result in cure. We know that. It's really going to be a combination of therapies. And like in other forms of advanced cancer, it may be a cocktail of 3, or for some patients they may require 5 or 6 for maximum effect. And again, this may not result in permanent cure, which is always a question that patients want to say, "Doctor, are you going to cure me?" And really the answer is no, we're really trying to make this a chronic disease, much like high blood pressure or diabetes. And we don't want you to die of this process. We want you to, live a long life, and eventually we all want to succumb to old age, which quite frankly is just a euphemism for a cardiovascular event. But as an oncologist, whether you're a urologic oncologist, a medical oncologist, or a radiation oncologist, our task, our endpoint is we don't want anybody to die of prostate cancer. So the therapies we need to get the data. We need to understand sequencing and combination. We need to understand sequencing and combination of timing of hormone therapies. We need to understand the anti-resorptives better, whether it's zoledronic acid or denosumab. And the trials are ongoing. And it's only when we do the trials, we get the data, we get a peer-reviewed assessment, then we can really have the answers that we want. I'm extremely optimistic that we'll have many of these answers within the next 5 years, certainly the next 10 years.